Thanks for joining us. We sincerely thank all of our speaker, Dr. Zofia Anna Nawrocka, earlier Microska, Dr. Hussain Ahmad Khaqan, Dr. Pramod Bende sir, Dr. Saravanan sir, Dr. Atul Dhawan sir, and all other participants to this webinar, which is called Learn from the Masters. It is session 4. Dr. Zofia will talk about the surgical aspects of optic disc pit. We previously had three previous seminars. The last one was on vitreoretinal interface disorders by Dr. Barbara Parolini, and previously Dr. Sengul Ozdek took a class on this pediatric retinal detachment, and Professor Ramji FC showed us nice surgeries on inverted island flap technique for macular hole. We have in the panel Dr. Hussain Ahmad Khaqan from Lahore, who is a senior vitreoretinal surgeon and a stalwart in vitreoretinal surgery. We have teacher of teachers, Dr. Pramod Bende sir, who has been teacher to many vitreoretinal surgeons in India and worldwide. He is currently a senior consultant and director of the vitreoretinal services of Pankaj Netralaya, Chennai. We have Dr. Saravanan sir, who is the chief of retina and vitreous services at Aravind Eye Hospital, Coimbatore. We have Dr. Atul Dhawan sir. This webinar is a brainchild of his only, and he is a senior consultant at ASJ Hospital, Kanpur. We are lucky to have Dr. Zofia Anna Nawrocka, earlier Microska, as our speaker. She has vast experience in macular surgeries. She is a senior vitreoretinal surgeon at Poland. She was the first to describe the inverted island flap technique, and which most of the retinal surgeons are using now. Thank you, ma'am, for joining us. I am answering my presentation.
Can you see the presentation?
No, ma'am.
Not yet, ma'am.
Okay.
Yes.
Okay. So first of all, thank you very much for the kind introduction. And I would like to thank especially Dr. Atul Dhawan for his kind invitation. I am very happy to be with all of you here today. And I will speak about a rare clinical entity that is the optic disc pit associated maculopathy. It happens extremely rare and even more rarely in both eyes of the patient, but the prognosis of this event is quite poor, especially because of the involvement of the macula. Here I listed to you some macular abnormalities that can be observed during the optic disc pit associated maculopathy. Most of our patients are young, which make the problem even worse. Even if we suspect bilateral optic disc pit maculopathy, you must take into consideration that it might be a different disease. Here you can see an eye with an optic disc pit associated maculopathy in his right eye. In the left eye, the patient also has subretinal fluid, but it's only due to central serous chorioretinopathy. We published a study several years ago talking about the misdiagnosis of this disease. And in fact, almost 75% of our patients are initially misdiagnosed and treated for a long period of time, for example, with anti-VEGF. So the most common misdiagnoses that we observed were AMD, myopic or idiopathic central neovascularization, central serous chorioretinopathy, or even retinoschisis. So we should be extremely careful when examining our patient with OCT only, because there can be an optic disc pit associated maculopathy, even if it's a rare disease. How to diagnose it? We can see it, of course, during our fundus examination, but maybe even better during fluorescein angiography, because there is leakage at the spot of the pit. When looking into our OCTs, we should focus on the optic nerve. We can note there the Elschling membrane, which you can see on the left-hand side of the image. That's a very thin membrane, which is visible on the top of the optic nerve, and that's visible in many cases of the optic disc nerve. We also published several years ago another appearances of the optic nerve in optic disc pit associated maculopathy. We can observe this porous tissue or even fluid accumulation inside the pit. What's maybe more spectacular is the fluid migration, the way of fluid that is pointed here by those white arrows, the fluid that goes from the nerve to the subretinal and intraretinal space. So now the first question, where does the fluid come from? So several years ago, Johnson and co-workers discovered mucopolysaccharides in the pit and suspected it is the fluid is from vitreous origin. Also, some experimental studies performed by Brown and Shields confirmed that we can inject a dye to the intravitreal space and it will come out subretinally. Another explanation was that the fovea detachment behaves similar to long-lasting retinal detachment. So if we inject gas, and that was the first method of treatment, then it is moved from the fovea to another place. It's also possible to drain the area of the pit and to remove subretinal fluid. Gas and colleagues found also some fragments of the vitreous body in the pit, and that would explain us the good results after removal of traction during vitrectomy. Here you can see some images of subretinal migration of gas or silicone oil, which was earlier injected to the vitreous cavity, which also confirms the vitreous origin in the fluid in the maculopathy. And now you can see a surgery during which the subretinal silicone oil is removed through the fluid needle pointed at the top of the optic disc nerve. And here you can see the remnants of silicone oil on the way from the pit and also in the center of the fovea. So the first suggestion would be never to use silicone oil in optic disc pit associated maculopathy. And not only because it can migrate subretinally, but there was also a study by Kuhn and co-workers, and the images you can see show us that the silicone oil might migrate to the brain, to the intracranial space. So it's extremely dangerous. So we never should use that. And also the presence of silicone oil in the intracranial space confirms us that there is a connection between the eye and the cerebrospinal fluid. Here you can see some schemes, but also images of other authors and of our group that show that there is a way of migration of the fluid from the nerve, from the suprachoroidal space into the intraretinal and subretinal area. And here you can also see how the dye that's membrane blue moves out from in one of our surgeries from the pit. So probably during the first injection, it was injected to the suprachoroidal area and comes out. Here is a video of a colleague of Anderson and co-workers. And here you can see that after gas injection to the eye, there is a long way when the gas comes out directly from the pit. So it must have been earlier in the supraarachnoidal space. So there must be a triple connection from the suprachoroidal space, vitreous body, and the intra and subretinal space. And that would be the first answer. Another point is, where is the fluid located in optic disc pit associated maculopathy? And we also performed a study on that topic. And we observed that the fluid can be present in the outer retina and subretinally, in both the inner and the outer retina, with or without the presence of an outer lamellar macular hole, and it can only be present subretinally in some cases. The natural course of the disease might be observed sometimes if the patient does not agree to surgery early on during the course of this disease. And I will share with you some patients that waited several months, and later I will show you several years of observation and how the pathology changes. Here you can see on the upper image, we can see only inner retinal fluid that further develops to an outer lamellar macular hole. And here is another example, also of a patient with inner and outer retinal fluid with a shallow fluid subretinally, and also later it evolves to an outer lamellar macular hole. And here is the third case. This is a patient that did not decide for surgery for about for many years until the visual acuity dropped. You can see that the visual acuity, when there was only subretinal fluid, was quite well. It worsened after it came down to the subretinal space, and then when the photoreceptors touched again the rest of retina, it improved a little bit. Later on, I will also show you surgery of this patient. So the most important question, probably the point you are all waiting for, is how to get rid of that fluid. During the past, there were several treatment attempts, of which most were decided not to work. So some surgeons tried to do only laser or pneumatic retinopexy, which have a very low anatomical and functional success rate. Also, there were some attempts of submacular plomb or radial optic neurotomy, which were abandoned due to the high complication rate. So we must all be clear about the fact that nowadays vitrectomy is the method of choice. But that is not that simple as it seems. So, of course, the first studies focusing on optic disc pit-associated maculopathy focused on simple vitrectomy with tamponade, air or gas tamponade in those eyes. The first complication we can come around with is the detachment of the posterior chyloid. Please remember that most of our patients are very young, so the detachment of the posterior chyloid can also be quite demanding. The problem with simple vitrectomy is, as most of us know, that the healing process is quite long, and sometimes it comes to recurrences. As I told you before, some surgeons decided to perform during vitrectomy radial optic neurotomy, but as this technique is quite demanding and associated with lots of complications, it's not used by many surgeons nowadays. Some surgeons used also laser during surgery, but Arevalo and co-workers confirmed in the international collaboration group that this technique, namely performing laser during surgery, is not helpful. It was a big group of patients, so probably nowadays we also should think that it is not useful to perform this additional maneuver, and that laser around the pit is not useful during surgery. It does not improve neither anatomy nor function. The probably biggest study on optic disc pit was performed by the European Vitreoretina Society, and I'm happy to be a part of that group. We operated on almost 100 eyes, which is really a big group of such a rare disease, and there were 25 surgeons from 12 countries. What we confirmed with that study is that vitrectomy and gas is better than gas alone or laser alone. And that's one of the very important take-home away messages. Another information was that laser during vitrectomy is not helpful. So we confirmed the study performed by Arevalo and co-workers. Additional information is that ILM peeling itself is not helpful at all. And what is very important, and which I will focus on in the later part of the talk, is that the second surgery improves only anatomy, but does not improve function. So we should really focus on the success of our first attempt. As I was introduced to, our group invented the inverted ILM flap technique. So it was also our idea about 10 years ago to use the inverted ILM flap in optic disc pit associated maculopathy. So initially, we tried only to perform a similar surgery to the surgery performed in macular hole. So we peeled a small area of the ILM and positioned it gently on the surface of the optic nerve pit. As you can see here on this series of OCT images, it was quite successful. So we achieved success in many cases, but it came to recurrences in some of them, and that led us to think about a new technique. So in vitrectomy, with ILM peeling, without ILM peeling, with the inverted ILM flap, or without, we still can observe some success, but it might come to recurrences. And that led us to the introduction of a novel technique, and that was the stuffing of the optic disc pit. We somehow the study was somehow based on another study that put a little part of sclera inside the optic nerve. It went quite well, so we decided not to only position the flap on the surface of the optic nerve pit, but to really push it inside. As I will show you in the next video, we usually use membrane blue because that's a very nice dye. It connects to epiretinal membranes, to the vitreous body, and also to ILM. So we do not need multiple dyes. We only use one of them to perform all the maneuvers. And as we know now, but some of the videos are from several years ago, we do not need to peel the ILM completely. We can do it only at the margin of the optic nerve. But as you observed here, we push it really inside with the Eckhart forceps. And here you can see the OCT and OCT angiography after surgery, and the thin line that is pointed by the white arrows, that's the ELM that was pushed inside the optic nerve, and it creates really a barrier between the supraarachnoidal area and the subretinal space. Here you can see the same maneuver with intraoperative OCT. And you can see how the ILM is pushed inside. You can see that this image and this video is performed much later. So we did not peel the whole ILM, only a small part of it at the margin of the optic nerve. And as you push the ILM inside, you can observe in this OCT that at some point of the surgery, it's really like sucked by the optic nerve. Now I would like to share with you the results of our study published several years ago in ophthalmology retina. And in this study, we focus not only on the results of stuffing the optic nerve with the ILM, but also of prognosis of particular patients. As you remember some slides ago, I showed you that the fluid distribution might be in at different positions. And I showed you also the evolution of the disease. So as you probably remember, initially the fluid is intraretinally. Eventually it creates an outer lamellar macular hole. And those early appearances of the macular hole were grouped together as group 2. And late appearances, namely subretinal fluid, were grouped together into group 1 in this single center study. So here you can see the fluid distribution and the main position of fluid in our two groups. So group 1 is this old disease, subretinal fluid, and group 2 is a more novel onset disease with mostly a fluid situated in the intraretinal space. And here you can see how the stuffing of the optic nerve looks during surgery, and of course OCTs and OCT angiographies. Here you can see the detachment of the posterior chyaloid. It's sometimes difficult to remove it only with vitreous suction, so we can combine both the Eckhart forceps or any other forceps you use for vitreoretinal surgery, and vitreous suction to remove the vitreous completely. As you can see, as I told you before, we usually only use membrane blue, and as this video was not performed that long ago, we did not peel the ILM from all the macular area, but only from the papillomacular bundle. That's very important as there were some reports of full thickness macular hole formation after removal of ILM from all the macular area. So it seems quite possible, even though I did not see personally any of such cases. We usually finish the surgery with air and position the patients for 3 to 5 days face down. Here you can see a series of events of healing of this process in a patient with intraretinal fluid. So probably a disease that did not last very long. And here is another example of surgery in a patient with intraretinal fluid and an outer lamellar macular hole. So probably a little bit longer lasting. And here also after membrane blue staining and after core vitrectomy, the ILM is peeled from the papillomacular bundle and the ILM is pushed inside. On some of the videos, you observe that we performed laser coagulation. As these are videos from the last 10 years, we did not know everything from the beginning. Some of those ideas I share with you today are novel data that were not known at the moment when those surgeries were performed. And here you can see the OCTs and OCTs angiographies of this patient from group 2 with an outer lamellar macular hole. And if you look more carefully at the OCT angiographies, you can observe a lot of artifacts on those images, which I will discuss with you in a moment. And here a case of a patient from group 1. So a patient with subretinal fluid, so probably the disease lasted longer than those two presented to you at the beginning, but the surgical approach is quite similar. So the ILM is peeled only from the papillomacular bundle and it's really pushed inside to the fovea. In all our cases, similar to macular surgery, similar to macular hole surgery, we only use air, and you can see that the ILM is really pushed inside. And even if there is some resistance, you should carefully try it once again and once again, because finally there will be suction from the optic nerve and the ILM will be sucked inside the disc. And here are OCTs after surgery in this patient, and you can see that the arrow points the ILM flap that closes the pit. What about surgical results? We observed the resolution of fluid in all cases with stuffing of the optic nerve, but the resolution was faster in patients when there was only subretinal fluid. So that's interesting because in a longer lasting disease, the anatomy recovered much faster. On the other hand, it was not that situation with function. We finally observed that better visual acuities were observed in patients with intraretinal fluid only, either with or without an outer lamellar macular hole. And that's probably because the photoreceptors were not detached for a long period of time from the retinal pigment epithelium. So the sooner we operate on those patients, the better the final visual acuity will be in them. Of course, this technique can be also implemented in the morning glory syndrome, whereas here usually we have a much wider detachment of the not only fovea but the whole retina. It's of course not possible to use perfluorocarbon in those eyes because there is not only a risk, but we can be almost sure that it would migrate to the intracranial space. So the peeling of the ILM from the detached retina is somehow more demanding than in just optic disc pit associated maculopathy, but still we can peel it around and also make a closure of the pit with the inverted ILM and the ILM stuffed into the pit itself. Here you can observe the surgery. Of course, in morning glory, it's better to use a bigger part of the ILM because also the opening is bigger. And on the upper images, you can observe the OCT before and after surgery. Also, this is an older video, so you can observe laser photocoagulation. And at the end of such surgery, we also use only fluid-air exchange. And what about OCT and NG-OCT appearances? You can see that in almost all cases, we see a hyperreflectivity in the fovea on OCT angiography. And that similarly as in macular holes, it's due to high transmission of light because of the very thin retina above. In scanning laser ophthalmoscopy, we can observe very strange figures that are probably associated with photoreceptor defects. And this is en face OCT, and you can see this very round lines, these circles, and those circles of different reflectivity, they show us where the photoreceptors are detached, where they are attached, and where they are completely absent. We should be extremely careful when calculating and looking at our OCTs, because OCTs and geographies create a lot of artifacts and in optic disc pit associated maculopathy. So we should always, before interpreting any results, make a very, very careful correction of all the OCT lines. But after doing that with the novel software, we concluded that the fovea vascular zone was smaller in group 1 when so the group with subretinal fluid when compared to the group with intraretinal fluid. So as a conclusion, I would like to state that the inverted island flap technique may not be enough to treat successfully the optic disc pit associated maculopathy. And because of that, we introduced the stuffing of the optic nerve, and it's a technique that presents long-lasting results and improves anatomy and function quite fast. And of course, even longer follow-ups with more patients will be more interesting, because optic disc pit maculopathy is a rare disease, and we always discover something else. Thank you very much for your attention.
Very nice lecture, Dr. Zofia. Very nice. Superb lecture. And now we can start the discussion part. The first question is from Dr. Ganesh. And the first question is from Dr. Ganesh, and he want to ask the question that if a patient with optic disc pit is coming to you without detachment or without NSD, so any prophylactic measure we can take like laser or not in that type of case?
No, there are many patients with optic disc pit who do not develop maculopathy never in their lifetime. We have no studies discussing the prevention, and I would not do any intervention in the situation the patient is asymptomatic. So if the OCT is good, I would not treat the patient. But even if the OCT is bad, and the patient has very good visual acuity and does not show symptoms, I would also wait with the treatment.
Okay, that means from your side, the laser is having no value, the temporal laser.
So that's the result of 2 big studies. So I would be quite sure of that, because first the group, the international collaboration group by Arevalo, and then EVRS confirmed that the laser is of no additional use during vitrectomy. Many of us do it because we are used to that. That was the primary idea, to make island peeling, laser, and gas. But I think the results from 2 big studies can show us not to do it anymore. We don't. It does not help us.
Madam, what about lasering on slit lamp without surgery? Like, is it an alternative to surgery? Laser around the optic disc pit in slit lamp.
There are also some studies that show us that only laser has the success rate of less than 40%. I wouldn't tell it is better than the natural course of the disease. So probably I would not laser a patient anytime. The slit lamp during surgery, I wouldn't do that. And I think there is a confirmation from the studies that vitrectomy is the technique of choice.
Pramod sir, what is your opinion?
No, that I agree with Dr. Zofia, because there are a couple of reports. Then again, these are isolated reports. There's not large study because number itself is low because of rare condition. But whether you do vitrectomy or any other technique, and even couple of reports with the laser also, and long-term follow-up. Recently, I think last year, one more report where it took almost 16 months for laser, post-laser fluid to get absorbed. Of course, we do not know whether it is a natural course or it is just big laser help. There's nobody has that answer. But yes, and that's the reason, right? I think still most of us are not really sure. We try always as a less conservative, less conservative techniques or less invasive technique, and progressively go for a vitrectomy. But yes, I agree with Dr. Zofia. I think most of us now as a probably first line of treatment would be vitrectomy in most of these cases, provided yes, patient is symptomatic.
Saravanan sir?
I just wanted to ask one question, like the tissues which we use to stuff the pit, both ILM as well as the sclera, they are not watertight tissues. They are permeable to water. So what do you propose is the exact mechanisms, how these plugging affects the closure? How does it, initiate closure? That's what's your proposed theory?
So that is a very that's an excellent question. So probably there is no much fluid that is coming to the subretinal space. So probably also those tissues allow to make a blockage for at least many years because the amount of fluid is very low. With the sclera, it's quite a thick tissue, so it's a big part of sclera that fills the optic nerve. I did never do surgery with the sclera, but that's what was shown in the papers. But with ILM, we perform it with multi-layers. So probably if there are multi-layers, it might help, let's hope, for as many years as possible. We must remember that those patients are very young and we still do not have results like from 20 or 30 years observation time. The longest observation is about 5-10 years. So I'm also very curious how it will be in the future.
That also does not answer because if it's a source if it's a suprachoroidal fluid, yet is one of your theory, and also it does not answer if it is a CSF, then how ILM will prevent it. We just don't know that part also. And again, how to, in spite of it, initial success, almost 25 to 30% patient come back with recurrence.
Dr. Hussain, what is your take about the laser, prophylactic laser, if the patient, if a 12-year boy is coming to you with a very small NSD and the patient is really reluctant for the surgery?
So can I have 1 or 2 minutes? Because doing it just as a webinar to run the time, I just want to share my thoughts about this disease. If you have 1 or 2 minutes for me, can I?
You can take 10 minutes also.
So that's nice. The issue is that everyone is showing his technique, everything. I respect everyone, whatever he is doing. But let me know, I got a pit patient, but listen me carefully. I get a pit patient with serious macular detachment, 32 years old. I just do the vitrectomy and next week, there is a no serious detachment and patient gets best video, best vision. Everything is fine. Do you have any answer for this? One. Second, I have a pit patient with a serious detachment. I do the vitrectomy. Nothing happens. Serious detachment increases next day. And then after 2 weeks, it increases more. Do we have answer for this? I have the answer. I have done 13 cases till the now. It may be very small series. And the answer here is that not every pit associated with the serious detachment has a one fluid source. It may has a 2 or it may not have even 1. If a optic disc pit has a serious detachment, only vitrectomy will work only in those cases where the vitreous is the source and vitreous has a plug in the pit that is making the source to the serious detachment. But how to detect those cases that where only vitrectomy will work? It's not possible. Second thing is then what to do? Either do vitrectomy once and then see whether it resolves or not. If it doesn't resolve, then go for stuffing something. So I believe that in all the pit cases, there may be 2 or 3 sources. You never know from which source in that particular patient is getting serious detachment.
So you should address all the sources in one go. That's my point. Third thing is that stuffing, as Dr. Saravanan said, I stuffed, Zofia, I just want to recall, I stuffed this pit with the amniotic membrane and put it like a hammer inside it. Next day, this membrane was floating in the vitreous cavity. There is a lot of pressure. Remember my word, there is a lot of pressure. It's not like this that there is no pressure. It pushes away everything if the source of fluid is from subarachnoid space. If the source is not from that one, it will stay there because there is no fluid gush. Even you showed the video where vision blue was coming out of it like in a gush, where oil is coming out. So it means there is a lot of pressure of fluid. So anything like ILM or anything, I don't know how it will stay there if the fluid is coming from that way. Third thing is that people are putting sclera. I put the punctum plug. That stuffs the pit as a complete 360 degree. And I just do the vitrectomy and put the punctum plug. And in all my 7 cases, serous detachment resolves from 3 months to 9 to 12 months. But it's slow. But in those cases, I didn't do any redo surgeries. That's just my point. I don't do laser. I have stopped peeling ILM. I have stopped stuffing with the amniotic or ILM or with homologous blood or anything. I just do the vitrectomy, detach the posterior highlight, clear the face of the pit and put the punctum plug. And I have a good case of series. I have 7 cases now with this technique, and our technique has been published also. That were only my concerns. So giving one technique and getting results in 2 cases is not the answer, because you don't know which is the source of fluid in that particular case. To identify the source of fluid is the next mission for this pit surgery, I think.
Yeah, can I add a few more scenarios here?
Yes.
Yeah. So now, just adding 2 more scenarios here. We all know and we all have experienced, there are situations everybody knows the fluid keeps on fluctuating. You can have a 1-day fluid and few days later this spontaneously fluid disappears. Okay, and vision improves. We all know that one. So again, so how to answer this question? And one more, recently I operated a case. Again, I cover the disc with a ILM flap. Patient come back like last week with that ILM flap is floating in the vitreous cavity. Of course, it was like an inverse flap. So along the edge of the disc, flap is floating, but macula is flat.
You see?
Okay.
You see? So
I did
in
not
that
expect it
particular
will happen.
patient, in that patient, the source was only the vitreous, not the pit for serous detachment.
Probably.
That you knew after the surgery. That's why I say detach the vitreous, stuff the pit with any plug. So you are dealing with the both pathologies, whether it is from vitreous, whether it is supraarachnoid space. So in one surgery, you kill the both enemies rather than playing ping pong with the patient.
Professor Hussain,
Doc-
can you elaborate the technique of putting punctal plugs in the optic disc pit? How do you do it?
How I do it? You just need to go. You just need to log in my channel and see how I do it. It's very simple. It's just 2 minutes job. You just Google Dr. Hussain Ahmad Khaqan YouTube channel and you will find it there.
Okay, Dr. Hussain, you are telling that by putting the punctal plug, you are cutting both the sources, means source from the vitreous cavity and source from the suprachoroidal space, that's subarachnoidal space.
No. By removing the posterior highlight, I am cutting the one source. By putting the plug, I am cutting the second source. That's my point.
But Dr. Hussain, as by my basic anatomical knowledge, this the connection of the optic disc pit with the subarachnoid space is not through the pit, it is below the pit. So even if you put something, even if you close the pit with the help of some punctal plug or sclera or some ILM flap, the the connection is below that level. So
I
how will you
totally
connect?
agree. I totally agree. That's why I am saying that if you have a pit like this, you cannot stuff it over here. You have to go deep inside it like it. So here it has a ILM connection. If you want, I can show you the video where
Okay,
I did it.
so that means you are telling that by putting the punctal plug, you are pressing that subarachnoid space entry into the subretinal space.
Yes, I am closing the connection of intraretinal space with the subarachnoid space with a long plug.
Okay, and what is your main complication in this surgery?
Main
Because
complication in this surgery till
yeah,
the day
because
till the day 7 cases, I have just one plug that has been dislodged, and I just removed it on the next day and repositioned it because the plugs are different size and the pits are of different size.
that's also a main question, that
Yes.
every pit is a different size and plug is
Yes.
a different size.
Yes.
So
So that's why in market we have 3 sizes available of plug. I am telling you, I have the 7 cases. In 7 cases, these three sizes fit very good. In one case, I thought the hole is pit is of smaller size. I put the smaller size punctum plug, but it dislodged next day. I just removed it and put the medium size. It's perfectly staying till the day.
Sir, if you have a video, short video, you can see if it is like possible.
Dr. Hussain, you can share your video now also. We will continue the talk, and in between, if you can share, we can also see your video, your technique also.
Sure.
The
I
issue,
just do it.
only issue is, see, we are directly pressing on a disc area. So
Yeah.
long-term effect, we do not know what is going to happen with, because we are looking at what, as Dr. Zofia said, these are young patients.
Okay.
We are looking
So
at the next
long-term,
20, 30, 40 years. What will be what will overall long-term effect? We do not know whether blood supply is going to get compromised or we are compressing on the nerve fibers. What will be, like eventually what is going to happen?
Dr.
Yes.
Pramod, I did this case in 2017, first case, and I let you know that the area along the pit having a glial tissue. It's not a real nerve tissue. So you are not compressing actually on the nerve, you are just pressing on the glial tissue. And it's not compression, it's the stuffing inside. It's not sideways compression. So you have to calculate the size and that one. And believe me, how you can block this hole with some paper thin things like amniotic membrane graft? You can't. As Dr. Saravanan said, these are all water permeable things. You have to plug it like a peg. So doesn't make a sense to plug it with the amniotic graft or something, a cotton triangular sclera. How it can block it? I just can't understand. It helps only in those cases where the source is not the pit, where the source is from the vitreous. And we think that our plugging of the amniotic membrane graft of anything is helping in removing the serous detachment. It's just our thinking is not that broader in that area. If you want, I can share my screen and I can show you that optic disc pit if you want.
Yes, please. I think in the meantime, we can take some audience questions. Like, yes, that has been would not stopping the ILM cause damage to the axons in optic nerve. Dr. Saravanan, sir.
That's what still there's all because of the paucity of the cases, we don't know, but forceful stuffing is definitely going to damage. And I think from Madurai, Dr. Naresh in his series, he showed that whenever he tried to stuff, there was anatomical closure, but the vision did not improve. By really pushing the tissue into the cavity, are going to cause a lot of damage. And even in the videos which were shown earlier in the talk, they were just placing it over. They're not trying to forcefully insert the tip of the forceps into the pit area. So that is going to do more harm than good. That's what I feel.
Sir, actually, the issue with the VN is something else. VN doesn't have nothing to do with the pit. VN has something to do with the serous detachment. How long the serous detachment is, how bad the VN will be post-operatively. So that's the issue with the VN. VN doesn't have to do with the pit stuffing. VN has a lot of issue with the series detachment duration actually. So can you see my screen, please?
Yes, sir.
Yes, sir. So here is my video. I think I recently presented it. If you can see it.
Video is not visible.
Yes, you can see.
No, video is not visible.
We just see your folder, not video.
Okay, okay, just a second.
Okay, till then, I would like to ask Zofia, which gas are you using for this surgery? SF, because you are saying that you are giving the instruction to the patient for only for the 3 days prone positioning. So are you using SF6 or you are using C3F8?
No, I'm using air. I don't use any long-acting gases. As you saw on the video shared to me by Anderson and coworkers, if you use long-acting gases, there is a higher chance that it will migrate into the supraarachnoidal space. So I always use air, and air is a typical choice for my surgery in macular hole, in optic disc pit. We really don't need a longer-acting gas than 3-5 days, so I don't use it.
Okay. And prone position only for the 3 days,
3 to 5 days, yes.
3 to 5 days prone position without any laser. That's sure.
So I think we must all be aware of the fact that most of us did not more than 10 cases, 20 cases, or maybe 30 cases in our whole lifetime. So it's difficult to say I never do it. Of course, I lasered some optic pits some years ago. Now I don't do it. But I think the most important thing about optic disc pits is focusing on those big studies that collected the numbers from different surgeons, because if each of us individually had such a small number of cases that we cannot really make good statistics. So all our techniques are very interesting and important, but I think the most important points are taken from the bigger studies that focus on about 100 or more cases from different departments.
Is my screen
Yes, yes, sir.
yes. So here you can see the plug. You can see.
Yes.
Yes. So this is the company that makes these plugs for punctums. I just got the idea and use these plugs. So you can see the shape of the plug. Atul, I would like to see here. You see the cap and this funnel, and this is arrow shape. This is closed at this end. And this is flexible. It is empty inside. It's not filled with the stuff. So it is flexible according to the shape where it will go. So now you can see the video. I will do it. Is it visible?
Yes.
Yes. So you can see the here is the pit. And this patient has got the ILM flap, and he got macular hole also after the ILM flaps. So here is the punctum plug. I am holding it with forceps, simple and grasping forceps, 23 gauge system, and you go inside. This is a pseudophakic eye. This patient has already underwent twice vitrectomy for optic disc pit treatment. So that's here you go. That's all. Nothing special and nothing miracle. You just go, you just have to point at the right place. Focus the pit area. Here you see, I have put it there, then check the position, and then slightly push it inside. That's all. Don't push it much. Just put it that it's still captured. So here you can see the punctum plug is lying the optic disc pit. That's all. So now no fluid from wherever, even you have a 50 mil micro pressure behind it, cannot push it away. Nothing can come out from this, never, and would never come. And this is just the continuation of the procedure, as the patient has got a secondary macular hole. So I am putting the amniotic membrane graft over the macular hole. So just a patient got something else also, so that's why. So this is what we do. So here I show you, just a minute. Sorry, it has something stuck. So here you can see, now Atul, you can see this is the head of the punctum plug. See it here? You see, this go
Yeah.
inside. So here you can see it goes inside, it closes from here. So this is how it works. This is how it works. That's all.
But still, Dr. Hussain, one thing is really not clear to me, that
Yeah.
optic disc pit is connected with the subretinal space in a horizontal manner, and your
Yes.
punctal plug is going into the vertical plane.
Yes.
So, so you are not putting the plug directly into the optic disc pit and closing it towards the subretinal side. You are putting it towards the subarachnoidal side.
So Atul, you see the cap stays over the area. Okay. From where the connection goes with the intraretinal space. You got my point?
Yes.
If you stop the fluid entering in the intraretinal space, your objective has been achieved. You nothing have to worry about anything. From where the fluid is coming, how it is coming, you just have to stop that connection of entering the fluid to the intraretinal space. If you see the drawings of Dr. Zofia, she directly showed you how fluid comes and how it moves. Where it moves on the right or left, there you have to put something that can close that connection. That's all.
Okay.
Hussain, I wanted to ask you also about visual acuity, because probably in the case you showed with macular hole, it was repeated surgery, so probably the vision was very, very low. Because
Yes.
in most cases, if we use amniotic membrane on macular hole, it is low, even without a pit. But what about
Yes.
primary cases? Did you do it in primary cases? And
Yes,
what about vision and visual field?
I did in a case, patient presented with to me hand motion, young patient, 18 years old. I did the surgery, just removed the posterior highlight and put the punctum plug. Next day, the punctum plug was in vitreous, in wet cavity. I had to readjust it according to the size. In that patient, in 3 days, in the nasal macular area, parafoveal and perifoveal area, within 3 days, fluid gone. But on the temporal side, serous detachment fluid took almost 3 months. But his VN gain was almost 80%. Believe me, VN has nothing to do with the pit. VN has to do how long the serous detachment takes. The patient that presents to me, they don't come on the first day. I just tell you one story. It's a very interesting story. I am a pit hunter nowadays. Patient comes to me on sitting on my slit lamp, patient with 6'9" VN pit and serous detachment, 6'9" VN, listen to me. And he has just a very small elevation in the nasal area of macula in parafoveal area, small elevation, not hindering the fovea. Patient said, I got blurring of the VN 6 days ago only. I said, okay. I said, I should wait. I cannot intervene. You have 6'9" VN, 6'6" VN. How I can go inside? Just, I thought it may be from longer. He just recognized. Believe me, I did the scan. It was like this serous detachment only on the nasal side. I asked the patient to wait for 1 week. Third day, not week, third day patient comes me with this serous detachment and hand motion VN. Will you believe it? Sometimes when it starts, it just take 2 or 3 days. So this disease has 2 connections. You should address these 2 connections. And I did vitrectomy only in that patient, no punctum plug. Because that was very furious patient, something like this, and VN was dropped in within day. I just did the vitrectomy, and believe me, this patient without ILM peeling, without stuffing anything, got 6'6" VN after 3 months. So that patient had the source of vitreous. You wouldn't find every patient with the source of vitreous. So you should have to address both sources. That's my humble thinking. If somebody understands, so it's okay. Otherwise, everyone is doing good job.
So, but how you decide, Hussain? how you decide in which case you will go for the punctum plug and in which case you will go for the vitrectomy?
Now I decide that I will go 100% in every case. In last 7 cases, I am going 100% in doing the vitrectomy and punctum plug. Except because in my beginning I said, is there a study or we can conduct a study where we can judge the preoperatively that what's the source of fluid in this patient? That's the main thing that we should understand before going for the surgery. If we find the source of fluid in that particular patient, then our surgical outcomes and surgical intervention will be far less than today. That's the only issue.
Any case of recurrence in your study?
Fit patient, no recurrence. 4 years maximum follow-up. All the others has less than 4 years.
Okay, that means no recurrence and 100% success by
In the plug patient, 4 year, the longest duration in 7 patients, and all other has less than 4 years. No recurrence.
Okay.
Dr. Zofia, we have a question in the chat box. What is the role of OCT angiogram in optic disc field?
I didn't hear very good. What is the
Role of
OCT
OCT angiogram in optic disc field?
Excuse me, I only hear OCT angiogram in optic disc pit, and
He wants to know what is the role of OCT angiography in the management or evaluation of ONH pit.
Okay, thank you. I think the role of OCT angiography is expanding more and more. There is no particular decision. I would focus on OCT angiography nowadays. It's still a very novel technique, and we can use it mostly for experimental, for science, just for science, not for really decision making in the patients. So just for explanation, when we talk about, for example, fluid migration, we also can only suspect it by some histopathological studies, but we proved the fluid migration with OCT. But OCT angiograms are used only for science, not for decision making.
Ma'am, any potential role in diagnosing of occult pits? Especially because the pit regions, they usually lack vascularity. So would it be a potential use to do a OCT angiography to see any signal void areas, and like can it be a suspicion for occult pits?
So I think each time we have a novel imaging device, it's useful to use it in almost all cases, because we never know what can be discovered with that. So we do OCT angiography in almost any retina case that arrives at the clinic. But I'm really not sure if there is any vascular changes we observed anytime in optic disc pit associated maculopathy.
Question for Pramod sir: How long should you wait for us after PPP to say that the surgery was a failure?
Well, it's a very extremely difficult question to answer, because that's why, as I said, like when you look at the literature, we are not many cases, but largest probably somebody has more than some 50 cases, and majority had having somewhere 10 or 21 cases or 7 cases or 3 cases. But on an average, when you look at anything, something between 3 months to almost up to 1.5 to 2 years, it took for pit to close. Again, we do not know whether it's natural course, because fluctuation we know, or is success of our surgery. And that's rather, I would pay main thing, and what Dr. Zofia in her presentation also said, like whatever you want to do, try as the first surgery, second surgery generally not really having good success rate. So really, whether you want to call as a failure, but give a chance and wait for a long time, but most of the time, second surgery, I won't suggest in this case. We just have to explain prognosis. And again, what Dr. Hussain, again, I agree with him. The vision depends, of course, associated subretinal fluid, if flattens down, that's good. But over a period of time, we have underlying RP changes. Those atrophic changes and structural damage to the overall retina eventually functional outcome probably will get compromised. So failure, to call it not, time only will answer. There's no exact answer for this question, but probably if first surgery doesn't work, most likely second may not work. And I won't suggest second surgery in this eyes. Maybe Dr. Zofia and Dr. Hussain can add on their experience.
So I think the most important thing about going to surgery are the symptoms of the patient. So I completely agree with you. Some of our longest observations were even a couple of years of patients with some maculopathy, but we also have patients observed for 10 years and more without developing any maculopathy at all. So that was, I would like to repeat again that if there is no maculopathy, we shouldn't do any attempt. But if there is maculopathy, we have big scale data that about 80% of those patients will progress. But still, as we know that most surgery types work well for 5, 10, maybe 15 years, we do not have longer observations. And those are very young patients. So I would wait with the surgery as long as possible as the vision drops, because still we cannot be sure. Even if I presented data that it's better to operate early on, I wouldn't operate on the patients with 0.8 or 0.9 vision just because I see the optic disc pit maculopathy, because I think the function will be better preserved if we just don't do it that early.
I agree.
Okay, and Saravanan sir, any role of only air tamponade and laser in the optic disc maculopathy?
That's what already as mentioned. I mean, some cases do succeed, but the percentage of success is not that very encouraging. So I wouldn't advise half measures. As a non-surgical therapy, a lot of people in India, when the patient is not ready for surgery or they're not sure about the outcome, they tend to do this temporal laser. But truly speaking, the success rate of these half measures are very discouraging. I wouldn't advise these.
And so Zofia is using air only. And what is your choice?
I use SF6 most of these cases.
PB sir, you?
Same. I agree with Dr. Saravanan.
You are also using that?
Yeah,
that
because see,
means
these are the eyes. It's not like any other retinal hole where you do laser and you need a tamponade for 2, 3, 4 weeks. Okay, here is something like the main source is like probably once you relieve vitreous traction, which is most common accepted one, and it is more because once you vitreous is because pull, and that creates a negative suction, and that while fluid gets stuck under the retina, and probably that is what the theory people propose, hypothesis rather. And if traction is relieved, probably you may not need any tamponade at all, but probably all of us feel that something we feel psychologically probably better to add on. So I think even air, okay, but rather we feel probably is more like our perception feels secure with a little bit longer acting gas, but C3F8 I won't use. Yes, Dr. Hussain.
Yes.
sir,
Sorry, I just want to
sir,
add, Atul, can I
okay,
get 1 minute?
yeah.
Regarding the laser, I tell you one point. The people had the success rate with the laser. You know, they have published and they have showed. You know why? It doesn't mean that laser worked in that cases. I believe those cases has the only vitreous was the issue of CS detachment. Laser actually didn't work in those cases. Actually, the vitreous was the culprit. They removed the vitreous and CS detachment gone away. That's why they claim that after the vitrectomy, doing the laser helped in that patient. I think so. Maybe that one. And regarding the tamponade, I don't find any reason of any tamponade in optic disc patient. I usually leave my patient under the BSS. No gas, no air.
How do you size this thing, punctal plug?
I go on the OCT and measure the probable size of optic disc pit, and then I know the sizes of punctum plugs, and then you can go, because it's not custom made. These are practically made. I have to choose from these 3 options until I don't find I have a custom made plugs for mine. So, the patients are not much. I get hardly 1 or 2 patients in a year. And in 1 or 2 patients, some patients are very young and they have very bad vision at the presentation, and they are not agree for the vision. So this is not the disease that you get once in a month. You get once in an year. Last 13 years, I just got 13 cases, and these are from all my colleagues even referred. I'm living in a 10 million population city. You believe me? It's not such common as the people are presenting the data. People are presenting 100 cases. I don't know from where the 100 cases comes. I'm living 10 million population city, surrounded by 5 million suburb, almost Delhi. How many people in Delhi? How many people in Delhi they got the optic spit in month? I think 1 in month in Delhi, maybe.
Hussain, the point is that to present 100 cases, you need like 20, 30 surgeons. Probably most the problem with optic disc pit and all the anecdotes associated with optic disc pit are associated with the fact that all of us don't see many of them. It's not retinal detachment. So we really don't know many things because it's so rare. Because of that, I just tried to focus on the fact that we have to collect big groups and to make big groups of doctors collecting all the cases.
Okay,
just to
that's why
evaluate
I am
the
saying,
thing.
that's why, sorry, I am saying that's why you should need to pick the countries with the bigger population to have the bigger data, not a countries with the 2 million or 3 million population. You have to pick the country with the 100 million population. Why you are going for 10 million population country?
Exactly. So that's the work for you and Atul, just to collect like 1,000.
I offered you, I offered everyone, but no one needs my services actually. That's the way. The people need the services of 2 million population people or 3 million population people, not of the 100 million population country. That's the story.
I think that's a big point, and it should be collected. The bigger optic pits, the bigger numbers we have, the more we know.
You want bigger number? You want bigger number? Ask the Atul. 200 million population country, they will give you 1 in 1 month. 100 million population city, I will give you 1 in 1 month. Why you are searching from the whole Europe and Latin America, where the whole population is not equal to India even?
But still, do you do optic pit every month?
We should get, no, Zofia, you know me. I talk only the real things. I don't talk on the screen things. That's why people don't like me much. But the issue is that we should talk as the real world is. We shouldn't
I like
talk
you very much, Hussain. As you know, I like you very much.
That's why I say we play ping pong on the conferences. We play ping pong on the webinars. I do this, but we don't speak the real truth. And we don't need 200 million population country, but we need 1 million population country for optic split. I don't understand. Sorry.
My question to the panel is, sometimes we see like there is.
It's just to keep the spice in the webinar, you know, to increase the rating.
My question to
Hope
the
next time you will not invite me.
Sir, my question to the respected panel is, like, sometimes we see features are similar to optic disc maculopathy, but the optic nerve appears normal. There is no other definite cause for that. So how do I treat that?
So one is it can be a hidden pit. Sometimes even the lamina cribrosa defects in what do you call vacillating glaucoma, people who have a high fluctuation IOP, the defects in the lamina cribrosa can act like a micro holes, that way producing a similar effect. So all
it has been described, particularly with the glaucoma having a larger cup and deep cup, it has been described similar way.
No, in cupless discs or very small cups with such retinocysis, peripapillary retinocysis, and sometimes outer macular hole.
Probably you rule out. Of course, it can happen. Like you said, like cup, the pit can be larger one, which is probably with a cover with glial tissue, so like a occult pit. But you can have a retinoschisis also. Probably you have to rule out if it is so. That can be another possibility. It can be totally independent pathology. I just have one more question here. Whatever mechanism that fluid goes through, source of the fluid. Now, if we have a very rare incidence, but we can still have a nasal pit. Okay. None of us have seen a fluid on the nasal side. Okay, macula is fine. But if mechanism is all I talk about, then something, some fluid collection, some schisis, something should have in retinal, in the nasal retina, but I don't think anyone has a braille. Again, it's again a very, very rare possibility within that all, but none of us has seen. Why does it happen? Nothing happens in those cases.
I think because the pit is on the temporal side, so it gets access to the interretinal space on temporal side. That's all. It have to take a long way. I think that's why there may be some tight connections around the optic disc pit that may not allow to go into the nasal side. But it's a very good point for food for thought that we should think why fluid doesn't go on the nasal side and why it's like this.
No. What I'm talking about nasal side fluid. Okay, I assume distance is far long, but at least then why can't you see fluid on the nasal retina? That's what I mean. Schisis on a nasal retina with a nasal pit. We never saw. Is it something to do with a macular architecture? So there it is more prone again as a fluid collection, temporal pit only. I'm talking about with nasal pit. We none of have seen like a nasal side fluid collection under the retina.
No idea.
Saravanan sir,
I don't
any
know.
hint?
No, I also agree with that. I have seen nasal fluid in patients with the optic disc coloboma, but not pit itself. Probably Madam can answer. Zofia Madam can answer if she has any inputs.
So I never saw fluid anywhere besides the fovea. Really, that's an excellent question. I never even thought why is it so. But now when you pose this question, maybe it has something to do with the connection between the retina and the choroid. Maybe it's more shallow, like in the fovea area, because we also do not observe another defects. Like, for example, we observed macular holes in the center of the fovea, but never, for example, at the fovea, at the vascular arcades. So maybe it has something to do with the connections, but that's an interesting question for the future.
I have seen one optic nerve coloboma patient who had more fluid in the nasal and inferior quadrant rather than in the macula. That is a one-off case. I don't know. I have not seen in pits, definitely.
Okay, Zofia, one thing last is suppose tomorrow on Monday, if you are in the outpatient department and you are seeing a 21-year girl, 21-year boy, girl is something different. 21-year boy is coming to you with the 1000 micron detachment, and the vision is 6/18 or 6/24. Whether you will go with the ILM flap or whether you will go for the simple vitrectomy only. That means whether in your case, in tomorrow, means when you are going from 0, tomorrow whether this ILM peeling is mandatory or not.
So what we know from studies, so what is completely sure for me now is that I would go for vitrectomy. I would not do any laser. I would peel the ILM only from the papillomacular bundle, and still I would just push the ILM inside I would not do the flap, because for me an optic nerve flap means something similar to the macular hole flap, that I only position the ILM gently. I agree completely with Hussain that we have to push something inside as deep as possible. So the kind of tissue we push inside might be discussed, because still we do not have big studies. We have only some single reports, like 15 cases from our group with the ILMs pushed inside. We have some cases from Hussain with this new device pushed inside the nerve. We can have some cases from amniotic membrane. So we really don't know what's the best thing to be pushed inside the nerve, but we can suspect that pushing something inside is quite helpful. What we need to examine is how the visual field, because we know it will be stable with OCT. Those patients won't have fluid anymore, but still we do not know how all the surgeries will influence our patients in 10, 20, 30, or 40 years. We don't have such long observation times. So we would need to compare those cases and meet again after 10, 20, 30 years and compare the visual fields of our patients. And that would be of special importance. But I would still use the ILM because it's a simple surgery then. We have the tissue inside the eye, we can push it inside. So I would do it. But again, what we are 100% sure, vitrectomy, no laser, and tamponade.
No, I just asked this question because so many young surgeons will see this talk. So take home message should be whether this ILM peeling is mandatory or this is an optional.
So I think ILM peeling itself is of no use. We have the EVRS optic pit study that shows that ILM peeling does not have any benefits. For the real scientific data, what we have for young surgeons, I would say vitrectomy, no laser, and gas. What is for me additionally interesting is pushing something inside the optic nerve. That's a new idea. It's presented by many doctors. It shows good result. I cannot tell you what tissue put inside the nerve is best. We did not do any comparative studies. So my choice is ILM. But that's only my choice. That's only my study. I cannot confirm you with 100% that any other tissue wouldn't be better. I just extrapolate from the macular hole results that still ILM is better than amniotic membrane, than anything else in regard of function. And function is the most important for our patients. But extrapolating between studies does not always reassure us with 100%.
Okay, Dr. Kaushik. Dr. Kaushik?
Yes, I think we had a good discussion. Do we have any more questions on chat?
I think we have already taken everything.
Yes. Then I'll take this opportunity to invite you all to our next session by Dr. Ahmed Salam on the art of scleral buckling. The date and the link will be shared soon. And I sincerely thank Dr. Zofia, Madam, Dr. Saravanan sir, Dr. Hussain sir, and Dr. Pramod Bende sir to sparing their valuable time and valuable comments with us. And we actually learned many new things today. And closing comments by Dr. Atul, please.
That was an excellent presentation by Dr. Zofia and Saravanan sir, PV sir, and Dr. Hussain. As always, they are very good in each and every points. So we have learned a lot from this presentation, and I would like to invite all of you for our next presentation by Dr. Ahmad Salam, and we will disclose. We will tell you the date and the time very soon. Thank you.
Thank you very much.
Thank
for
you.
this
Have a good
nice
weekend.
learning
Have a nice
experience.
weekend. Bye.
Okay, why can't you get one screenshot with everybody's video on?
Yes.
Just request everybody to have video on and take one nice screenshot.
And smile.
Yes, obviously, yes.
Not photo without smile is like a statue, you know. Photo without a smile is like a statue. So you want a statues? No.
But we don't want blank screens also.
Blank screen people are more beautiful. They don't want to sell their beauty.
Thank you. We from academic cell, we have Dr. Mayank and Dr. Ganesh also. And if they, Dr. Ganesh and Dr. Mayank.
Yeah, thank you, Dr. Zofia, for the wonderful presentation. It's a very interesting topic.
You are muted, Dr. Ganesh.
He's speaking, but I think the connection is not that very great.
Right. Thank you so much.
Thank you. Thank you.
Thank you.
Bye.
Thank you. Nice seeing you all.
Zofia, I am flying today to
Have a nice
over the Poland.
weekend.
Be ready.
Whatever leftover
I'm
weekend, you
landing
can have a
in
nice one.
Norway today.
Bye-bye.
Bye. Bye.
Great day, everyone. Great weekend.